Hi, I'm Dr. William Starziak, and thank you for joining me in this beautiful meadow to learn about osteopathy. I'll be giving two presentations. The first presentation will be on a brief review of palpating the cranial mechanism, and that's the one I'll start with here. I am at home. You might hear my daughter in the background. This is my first time recording a Zoom meeting, so please bear with me. Go ahead and open it up here. Let's hit share. Okay. All right. So I live here in Indianapolis. I'm an osteopath. I have a private practice over on the west side. I've been in practice since 2013, focusing on osteopathic manipulative medicine, mostly in the indirect spectrum, osteopathy in the cranial field, BLT, FPR, indirect myofascial release. But I also do some primary care, some addiction medicine. We have a few massage therapists on staff as well. And I worked for 5 years at Marian University's College of Osteopathic Medicine, teaching in the labs. Okay, so osteopathy in the cranial field. Here's a quote that comes from the DO who's credited with the discovery and really fleshing out of cranial osteopathy, William Garner Sutherland. And this is from the moment when the idea struck him. As I stood looking and thinking in the channel of Dr. Still's philosophy, my attention was called to the beveled articular surfaces of the sphenoid bone. Suddenly there came a thought. I call it a guiding thought. Beveled like the gills of a fish, indicating articular mobility for a respiratory mechanism. And it's interesting how here he really sidesteps any egoism in making a point to describe this as a guiding thought, not a thought that he credits to his own personal self-identity, but that it was something that came to him as if inspired. And I think that's a powerful place to begin from, rather than from a place of ego, from a place of inspiration. So Dr. Sutherland then went on to look into this. As A.T. Still would say, he kept digging. So he brought this idea to Andrew Taylor Still, and Still said that he had the right sort of view and mindset on this, and that he should keep digging into it. And so he did, initially mostly on himself. Different experiments that many of us have heard of. He would restrict his head with a vice clamp and on top of a baseball glove, and then take notes on what happened. And he would have to call his wife in to help release something that he had stuck. And so he started to study how the head moved and what would happen when it could no longer move. And there's a lot of interesting stories that come out of that study. But then eventually he started teaching it. And we'll loop back around to how he started teaching it here at the end. But let's just go ahead and go forward. These are some things that he discovered, that there's an inherent rhythmic motion of the brain and spinal cord. And this is not theoretical. This is something which can be observed during spinal surgery. The rhythmic tugging of the dura is a known phenomena amongst spinal surgeons. And then also the motion of neurons can be observed in vitro. They pulse. And I'll present some evidence that supports that. And then the fluctuation of cerebral spinal fluid. So there's a creation, a flow, and an absorption of cerebral spinal fluid. The creation occurs in the ventricles, the lateral ventricles, and in the choroid plexus in each lateral ventricle. And then it flows through the ventricles and comes out at the brain stem, flows around the brain. Some of it is reabsorbed in the arachnoid granulations. and then it flows down around the spinal cord inside of the dura, and most of it is reabsorbed down at the lower end of the spinal cord. And then mobility of intracranial and intraspinal membranes. So this is just meaning that the dura, the meninges, and then the falx and the tentorium are mobile. So they're not rigid, they're not stuck, they have the ability to move. And then so do the cranial bones. And this was implied by this quote. This is what kind of started Sutherland off, is that looking at the way the temporal bones were beveled, they reminded him of the gills of a fish. So beveling, most of us may know what it is, but some people might not. So I'll just give you a brief explanation. Like if we take my phone here, my phone is, put it up to the camera, is slightly beveled. So it's rounded here on the end, with the round part kind of facing upward. So another way to conceptualize beveling would be like how these two things fit together. There's an upward facing bevel. It's a slanted surface, and then there's a downward facing bevel. You'll see this on the edges of tables, beveling, where it's kind of rounded and it's facing up, or it can be a flat bevel. It's just a flat angled surface. And when you look at the temporal bones, we'll go over the beveling at the end, but you'll see that they're beveled. And it really implies that they are gliding across each other. And there's bevel changes too within the head, which has the effect of limiting motion as well. So if we take a hard hit on top of our head, in our temporal bone, the beveling switches partway through. So instead of the bones being able to slide past each other, they actually get stopped at the area where the bevel changes. And so that's where people tend to get stuck in their cranial bones, is at bevel changes, because those are what stop the bones from being able to slide past each other. So it's also good information to have for treatment. And it ties right into one of our 4 principles of structure and function are interrelated. So by going to the anatomy and looking at the anatomy, we can induce the function or deduce the function, and that can actually help us with our treatment. And then this involuntary mobility of the sacrum between the ilia. So because of the connection between the head and the sacrum through the spinal dura, motion that occurs in the head is translated through to the sacrum. And so that's going through a rhythmic back and forth motion. So this is often referred to as the primary respiratory mechanism. Sometimes it's more poetically referred to as the breath of life. Sutherland would call it that quite a bit. But primary because it's first in importance. It's thought to actually precede respiration, so thoracic respiration, the exchange of oxygen in the lungs. It's thought to be more primary than that in importance. And there are these physiologic centers that are located in the floor of the 4th ventricle. They regulate pulmonary respiration, circulation, digestion, and elimination, and they depend on the function of the CNS, and they're involved with the maintenance of life. So they're really primary in the maintenance of life. So this is why it was theorized that this was a primary respiratory mechanism, because the respiration that occurs there is really directly affecting the floor of the 4th ventricle. It's increasing and decreasing pressure that these nuclei sitting at the floor of the 4th ventricle experience. This is the same reason why Sutherland's first cranial treatment that he taught people is how to compress the 4th ventricle. Also known as bulbar compression was what it was initially referred to as. Now, respiratory refers to exchange of gases and other metabolites at a cellular level. and mechanism implies that it's an integrated machine. So each part is working in relationship to every other part. Here we see one of our 4 principles again, that the body is a unit, that everything is one. We can, for purposes of learning about it, we can dissect it out and we can look at individual parts, but really we can't understand the whole by just understanding the parts. We need to look at everything as a whole. And then this exchange of gases and metabolites, one of the theories about the cranial rhythm is that it's actually involved with the transfer of metabolites to and from the smallest of the blood vessels through the interstitium. So when you go down to the arterioles, and then you go through the capillaries and the venules, as they're releasing these nutrients, and then also the venules are reabsorbing metabolites, that it's this wave-like motion that's conducted through the entire body that's actually giving the motive force for the movement of those things from those cells back into the vascular system, and from the arterioles out to the cells, much like waves would be moving on a beach and circulating things back and forth from the sand and the ocean. So we've had quite a bit of research in it, and I'm going to present just a few of them here. One of the very common things to run into is people denying the possibility of the head moving without having looked at any of the evidence, but merely assuming that their intuition about it is correct and saying the head can't move, and that anyone who thinks it does is a quack. And this is an interesting position to take, because they're saying something is not based on evidence without looking into the evidence. So that, that is the definition of hypocrisy. We shouldn't just believe anything anyone tells us, but we should have an open mind and look at the evidence. So back in 2009, Dr. Thomas Crow and some other folks published a study assessing the calvarial structure motion by MRI. This was published in Osteopathic Medicine and Primary Care. So they took serial MRIs over time, and they showed that there was motion in the head moment by moment, that it changed shape. And one way they measured this was the longest distance between the outsides of the skull. They called the ferret, that the ferret would moment by moment change shape. So to me, that alone, if you have a study demonstrating that, we know the head moves. So it seems pretty cut and dry that the head is moving moment to moment. And since then, there's been other research. I've heard about research NASA's done to look at the effects on the head in zero gravity. I don't have any of that on hand, but that if you're interested in digging deeper yourself, you may be able to come across some of that. But so we know the cranial bones are moving. We've demonstrated it. So then more research, Greetz et al. Using magnetic resonance imaging technology also demonstrated that the brain tissue moves. So this is speaking towards the inherent motility of the central nervous system. And it's characterized by a caudal, medial, and posteriorly directed movement of the basal ganglia, and a caudate and anterior movement of the pons during cardiac systole. And the resultant movement vectors create a funnel-shaped appearance in the brain, and which results in a piston-like remolding of the brain. The authors felt that this piston-like action of the brain during cardiac systole was the driving force responsible for compression of the ventricular system, and thus driving force for the interventricular flow of cerebral spinal fluid. So this is suggesting a mechanism different from the cranial rhythm as the dominant propeller of cerebral spinal fluid. It certainly could be a both and, but the pulsation of the brain is creating a pressure change that is changing the shape, or the pulsation of the arteries are creating a pressure change that's changing the shape of the brain and acting like a pump for circulating cerebral spinal fluid. But we're going to tie this in later with the CRI, why that, this quicker pulsatile rate is likely not the only thing that's going on based on the evidence we have. The Nensman and Pelk demonstrated brain motion during the cardiac cycle utilizing a similar MRI technology. This showed peak displacement of the brain ranged from 0.1 to 0.5 millimeters, except the cerebellar tonsils that demonstrated displacement of 0.4 millimeters. So we got a lot of these similar studies showing the changing shape of the brain. And let me see, I have my sources listed. Let's see here at the end. These are all color-coded. So anything that's in green, this is coming out of Foundations of Osteopathic Medicine. So that's why I'm not in-depth citing the Greets and the Poncelet and the other names there while I'm just noting them there. So you can go in and look in Foundations to find the detailed citations. Orange is Di Giovanna's approach to osteopathic approach to diagnosis and treatment. And then the Nicholas Atlas of Osteopathic Techniques is in this kind of peach color. And then the application of still technique is in this light blue color. Which we don't really, those last two, we just have a little bit from. Okay, so let me go back up here. All right. Okay, sweet. So Poncelet et al. Using echoplanar MRI, they were able to demonstrate pulsatile motion of the brain parenchyma. Brain motion in that study appeared to consist of a single displacement during systole and a slow return to baseline configuration during diastole. And this displacement included a descent of the midbrain and brainstem toward the foramen magnum. So that same sort of caudal motion that was described in this study here was observed here as well, with the magnitude and velocities of greater than 2 millimeters per second, and medial compression of the thalami. So that's the same thing we saw here. The caudal and medial, and then posterior direction of the basal ganglion. So it's that medial motion of the thalami. And onto the third ventricle with a velocity of 1.5 millimeters per second. So the list goes on. You can look through Foundations and find there's more and more evidence. I just pulled out some of the highlights. These pulsatile contractions have been observed in vitro in brain cells as far back as 1935. That shouldn't say as far back. That should say as far back. Sorry about that. So it's been known for quite a while. All right, so here's some more research. This is coming out of the Journal of Osteopathic of the American Osteopathic Association in 2009. And this is where they are recording the cranial rhythmic impulse. And this, to me, is one of the most interesting studies. Because even if we all agree, across the board, okay, the head is changing shape. Well, then the question is, are we really able to real time feel the change in shape? Are our hands sensitive enough? And this study suggests, yes, our hands are sensitive enough. What was done in this study is pretty cool. So they took laser flowmetry devices and they attached it to someone's ear. And with that, they're able to follow an autonomic phenomena called the Traub-Herring-Mayer wave. Now, the Traub-Herring-Mayer wave is evidence of oscillation in autonomic input. Basically, it's like our nervous system is passing dominance back and forth between the sympathetic and the parasympathetic. Because nothing in life is static. Nothing that alive is in a static state. Everything is moving. Everything is breathing. And the same thing is true of our autonomic nervous system. It is passing back dominance from the fight or flight, urgency, sympathetic system to the parasympathetic, rest, relax, digest, reproduce system. And this shows up as fluctuations in heart rate variability, as vasoconstriction and vasodilation, as blood pressure changes, as heart rate changes. So heart rate variability, when sympathetic dominance increases, heart rate variability decreases. When parasympathetic dominance increases, heart rate variability increases. So we end up seeing this sinusoidal wave pattern if we look at blood pressure, heart rate variability, vasoconstriction, vasodilation, because they're receiving kind of competing inputs from the sympathetic and parasympathetic system. So in this study, they demonstrated a significant correlation between the palpated CRI and this 0.1 to 0.15 hertz Traub-Herring-Mayer wave or Traub-Herring oscillation that they recorded by the flowmetry. And they further demonstrated that cranial manipulation specifically affects the Traub-Herring-Mayer wave. So this is my theory, and I think other people share this theory. I haven't read it anywhere, but it seems the natural conclusion that comes from this sort of observing this phenomenon. That perhaps the motion that we feel in our hands could be a combination of two things. So one, it's that this varying rate of sympathetic dominance and parasympathetic dominance may accentuate and de-accentuate the effect of cardiac systole on changing brain shape. So every pulse, systole is creating a change in the brain. But when you have a higher sympathetic tone versus a higher parasympathetic tone, that the degree to which it changes could vary. But the other piece that I suspect is because muscles are also innervated by the sympathetic and parasympathetic systems, and that increased sympathetic tone results in increased muscle tension, that when we go into the phase of increased sympathetic tone, we are increasing tension on muscles throughout our body. And the dominant muscles attaching to our head, when they tightened, they would end up pulling the head into flexion. And what we see in this study is that when sympathetic tone is increasing, where in the Traub-Herring-Mayer wave, we're seeing increase in blood pressure, or we're seeing decrease in heart rate variability, that's when practitioners are palpating flexion. I'm getting a little bit ahead of myself here. Let me loop back around to this idea after I explain these findings a little bit more. So the inconsistency between palpation and instrumentation, because they did see some inconsistency, may also be explained by observations that most examiners in the study, they were palpating the CRI so that flexion was perceived coincident with one Traub-Herring-Mayer wave beginning, and extension was being perceived with the beginning of the next wave. So if we look at this image here, and you see A, this exhibit A, so saying here, most physicians tested would palpate flexion and extension at the same point of increased sympathetic tone. So this point where it says F and E, that's when most physicians were calling out flexion and extension. But physiologically, this is the same phenomena. So why would the cranium be moving in a different way when we're experiencing the same physiologic phenomena, increased in sympathetic tone? This is just a zoomed out image of the same thing. Of while these practitioners, I really got ahead of myself, because what's happening here in the study is these practitioners are palpating a person's head while the laser Doppler flowmetry device is on their ear, and it is following the Traub-Herring-Mayer wave. And then the physician who's palpating the head is calling out when they feel flexion and extension. And this image B, A and B, are what the majority of physicians felt. They were only discerning one point of the Traub-Herring-Mayer wave, and that's the increased sympathetic tone. And that, in my mind, is the flexion state. And we'll explain to you why I'd say that's actually the flexion state. But it is the most obvious point to feel when the temporal bones are moving out laterally. And we'll go into the precise motion pattern of the head here at the end as well. But there were a few people who palpated it, as you see in this image below, where they were actually saying flexion when the sympathetic tone was at its peak, and then extension when the parasympathetic dominance was at its peak. So that's pretty cool. To me, those folks have the greater sensitivity. And this also explains why, as we look back through osteopathic literature, we really see two different frequencies arise. There are many studies that are saying we should be feeling a full cycle every 6 seconds. So be seeing 10 cycles approximately per minute. But then there's a whole bunch of other studies that are showing that we should only be seeing 5 cycles per minute of the cranial rhythm. And then this study beautifully explains all of those findings. That, well, yeah, it makes sense why people palpated it at these different rates, because some people were not able to feel this passive state that was the mechanism relaxing. They were only feeling something during the active state of things tensing, and then as it relaxed, they missed it. And so they didn't feel anything again until they felt some motion. And so they just figured, I feel something, so I'm just going to alternate between calling what I feel flexion and the next thing I feel extension. But it was the same phenomena. So this study to me is really exciting. Okay, so the methods resulted in a ratio of palpated CRI to recording of the Traub-Herring-Mayer of 1 to 2. This higher palpated rate, reported by Woods and identified in osteopathic medical textbooks, is consistent with the rates obtained by instrumentation. And then it's also worthwhile to know, this is the thing here, is that some of the examiners in this study did palpate it at the 1-to-1 rate. So this is just already what I just explained here on this next slide. Most people felt it this way, some felt it this way, and this explains why we see this difference in previous research, where we see both of those rates. Okay, and here's another study that's, so this study also concluded that they were able to demonstrate that cranial manipulation affected the Traub-Herring-Mayer rate. So when rates were slow, they were able to speed them back up, and also physicians were able to induce still points, and they could say when there was a still point, and when a still point was present, the waveforms would actually become still. You would no longer see this nice wave, and I didn't grab a picture of that for you, but you can go to this, just Google this, recording the rate of the cranial rhythmic impulse, and you'll see it come up on the JAOA, and you can look through, and they show images of that as well, of inducing still points, the practitioner calling out when the still point is there, and then calling out when it resumes, and also affecting the rate of the Traub-Herring-Mayer wave. I mean, this is exciting because we literally have a handle on the autonomic nervous system, which is implicated in all manner of diseases. The vagus nerve has the ability to send anti-inflammatory signals to the spleen. So then this creates a proposed mechanism for how to explain how many of us who do manipulation see benefits in people with autoimmune diseases, that we're decreasing someone's immunoreactivity through a cranial mechanism via the vagus nerve to the spleen. So there's a lot of exciting research that can be done going forward from this. But so this next study looked at variations of the high frequency parameter of heart rate variability, and that's from parasympathetic input following osteopathic manipulative treatment. And it was randomized, controlled, and they used sham therapy to control for it. And this found that OMT could affect the autonomic activity and increase parasympathetic function and decrease sympathetic activity compared to sham. And there are quite a few studies that demonstrate this, that cranial manipulation will decrease sympathetic arousal. So what this means is that people receiving osteopathic treatment, cranial treatment, are going to be less susceptible to stress. That when they have stimuli that are potentially stressful, they won't result with as much sympathetic tone, but they'll stay more relaxed. And that gives people, helps them retain access to their full resources and to think things through logically, to stay calm, to avoid conflict. So pretty cool. Now, this is one of the other studies that's very exciting, and it's brand new, November 2019. Hope Toby, Dio et al., looking at the effect of osteopathic cranial manipulative medicine on an aged rat model in Alzheimer's disease. And down here, this just says that, it's known that the pulsatile activity by the vascular system on the brain, it reduces with time. So arteries become stiff over time. And so that's going to affect fluid exchange between the different compartments. And it could be part of the mechanism that leads to the neuroinflammation that results in Alzheimer's disease. Now, in the past few years, when I was in medical school, they taught us the brain didn't have a lymphatic system. I think all the DOs doing cranial manipulation were treating as if it did, but for some reason, the thought was that there wasn't one there. But it's been conclusively proven through anatomical studies that there are lymphatic vessels. So this really opens up this idea that perhaps cranial manipulation could help with clearing these metabolic waste products and reduce the risk of developing Alzheimer's, or maybe help to turn around this condition of someone who's already developed mild cognitive impairment. So this is what this study wanted to look at, is using this first treatment that William Garner Sutherland developed, the compression of the fourth ventricle. Could they accentuate clearance of these beta amyloid plaques? So they used a rat model, and if you look up this study, you can find images of them applying this to the occipits of rats. So teeny, 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 teeny. And I don't think they were palpating the cranial rhythm while they were doing it. If they were, that's super impressive. They basically have their thumbs in there like this, and they would be doing the compression that way. And they had some really cool findings. So what they found was these rats, and these weren't normal rats. This was an aged rat model. So these were rats that began to show were bred or raised for having to demonstrate mild cognitive impairment, to serve as a model for studying that. And this is a standardized way of studying dementia, is looking at these aged rat models. So it's nothing unique in this study. But so they took this particular type of rat, and they applied this fourth ventricle compression. And what they found was that that the rats had significant improvement in spatial memory after 7 days of these cranial manipulation sessions. And that while they were still alive, they did these positron emission tomographic images and immunoassays, and they revealed that it reduced beta amyloid levels, which is implicated in Alzheimer's disease. Now, there are other studies that show with medications that can clear beta amyloid that symptoms don't improve. So it may not be just about clearing beta amyloid, it may be about preventing it from ever accumulating. Like maybe once it's accumulated, it's already created some damage that isn't going to go away by clearing it? Maybe not. I mean, this study showed that it reduced beta amyloid levels, and it improved spatial memory, and it activated astrocytes and improved neurotransmission in aged rat brains. So pretty exciting, pretty cool, because Alzheimer's is one of those really scary things that's out there that we don't have anything great for yet. So here's a possible mechanism that could support further research into it with human studies. So hopefully we'll be seeing that in the next few years. Okay, so that I feel like is plenty of research for you to give this the benefit of the doubt if you're already on the fence about cranial osteopathy. And so now we'll just talk about, well, what are the motions that are observed? And I'll tie that back into my theory about, it's not like mine alone, I'm sure other people have the same thought about why this subset of physicians is palpating flexion when sympathetic tone increases and extension when sympathetic tone decreases. So in these models, if you follow the arrows, you see that flexion at the sphenobasilar junction looks like this. Extension at the sphenobasilar junction looks like this. And this is a gross exaggeration, but you get the idea. So like it's rotating about an axis, and you see the axis is there on the screen. So when flexion, we have all of these muscles attaching to the back of the occiput, and then the muscles of mastication attaching to the pterygoids. So when sympathetic tone increases and the muscle tension increases, well, that is going to tend to pull the head into that position. The back of the occiput will be pulled down on, and the pterygoid plates will be pulled down on. And because this will, the pterygoid muscles angle backwards, so they go posterior and inferior, then that will cause the sphenoid to tilt forwards. And because these occipital muscles are all touching here on the back and they're pulling down back here, well, then that's going to pivot the occiput to go backwards. So to me, it's a really beautiful explanation where the autonomic phenomena we observe with the laser Doppler flowmetry, and that we can palpate synchronously, and how we know the head moves, it all fits together so beautifully. And then so, you see extension there too. So then extension would be a relaxation phase as the tension in those muscles. And again, this is theoretic. The official stance in osteopathy is that it's not known how this motion occurs. But in theory, it would be reasonable to think that then when parasympathetic tone increases and sympathetic decreases, then the fascia, the fronto-occipital fascia and muscles here, the tension of the fascia would help the rebounding back that way, as well as the reciprocal tension membranes in the head, the falx and the tent. They would also cause it to rebound back into a resting position. And it's interesting to note that when we inhale, that will induce a flexion, and when we exhale, that will induce an extension. Inhalation is active, we're seeing muscle contraction, and so it's going to we tend to brace as we inhale and activate other accessory muscles to a small degree, and then exhalation is a relaxation phase where things return to normal without effort. So that the active phase produces flexion and the passive phase produces extension. I think that further reinforces this idea that the autonomic variability we see and how it can affect muscle tension could be behind the palpated motion. So these are views from above to show exaggerations of what happens during flexion and extension. So exhalation is extension, and inhalation is flexion. So we have a few different terms that come in to cranial osteopathy that kind of make things a little confusing. But if you remember that when you exhale, you go into extension, and when you inhale, you go into flexion, then it's easy to associate inhalation with flexion, exhalation with extension. So during extension, the anterior-posterior distance increases, the side-to-side distance decreases, and then the opposite happens in flexion. AP distance decreases, side-to-side increases. So when we're in Volthold, we'll feel this widening and narrowing of the head. And this shows the cerebral spinal fluid circulation. So you see here the choroid plexus and the lateral ventricle. There's one in each lateral ventricle. It sits on the bottom of them, kind of right above the, or right beside the hippocampus. It produces the fluid, the cerebral spinal fluid, that then goes through the lateral ventricles into the third ventricle that's between the thalami, and then that goes down into the fourth ventricle, and then it comes out around the brainstem and circulates through around the head as reabsorbed in the arachnoid granulations, and enters the superior sagittal sinus as well, through the granulations, but then it goes down along the spine too. Here we're looking at the anatomy of the reciprocal tension membrane. You see the falx here, the tentorium. So just like if you were treating someone's ankle using balanced ligamentous tension technique and you're finding the balance of tension, well, there's a balance of tension in the head. I mean, these are membranes, or maybe, it'd be more appropriate to liken it to where you're treating you're doing intramembranous treatment between the fibula and the tibia, and you're finding balanced membranous tension. Well, when we get, just like most of us who do any degree of manipulation have at some point or another felt a floppy ankle. That's one of the easiest things to impress someone with. You pick up their legs and you feel their ankles, and one of their ankles is just floppy. And without them telling you, you could say, oh man, you really sprained this ankle bad, didn't you? Because a mild ankle sprain won't make the ankle really floppy. But a bad one will make it so that it just really readily inverts and goes into that supination position. So we see that imbalance in ligamentous tension. So the membranes in the head are made of the same sort of stuff in a different distribution, of course, and they have a different shape than those ligaments, but they operate under the same basic principles that when they experience a trauma, part of them will tighten up, part of them will loosen, and then they will pull on the head. And so when we're treating, we're allowing the motion of the cranial rhythm as we follow it, we're allowing it to draw the head into its position of balanced tension is the way to work indirectly, as opposed to oppose it and try to stretch it out. But if every cycle you feel what's easiest for the head, and you just let it do what's easiest and you support it and you stay right there with it, then you're going to reach this point just like you would in an ankle or a wrist or anywhere else in the body. You're going to reach this point where it gets still. Frequently at this point, I notice if it's a deep thing that's from like really old, when someone got hit really bad in the head when they were young, I'll have patients fall asleep at that moment when it gets still. Like they'll start snoring. And then when it releases and it starts moving again, frequently the patient will wake up right afterwards. And when I'm using like 5 pounds, because sometimes you need to use a lot of force. In the beginning, we should be very gentle and use very little force. But sometimes the structure will guide you into applying a decent amount of force. Where normally if someone was pressing on your head in a weird way, or just pressing on your head with 5-10 pounds of force, there's no way you're falling asleep. But I've seen it too much where you balance it just right and they just fall right asleep and it releases and then they wake back up. To me, that's a real, like, in addition to them getting better, it's a real-time testament of the phenomena that's occurring, a resetting in the balance of tension inside of the head. So studying this anatomy and having it as second nature is then going to help you when you go to treat. I'm not saying that you should obsess about this anatomy and try to really intensely visualize it in your head while you're treating. It should kind of naturally be there to assist you as you're interpreting what you're feeling. And here it also shows you the connection down with the sacrum. It's just cut. It's not really cut in a human. It's just that for the sake of the picture, so they don't draw the whole thing out. And then this is a diagram of the venous sinuses in the head. So looking at how they're oriented around the falx and the tent, you can see that the motion present in the head conducted through the falx and the tent aids in draining the venous system of the head. So there's a mechanism for decreasing headaches and also improving centrally mediated hormone release, because if we have venous congestion or lymphatic congestion, well, that could have some metabolic effects that could create some low-level hormonal effects. And so this, mechanisms for why osteopathy has been shown to improve quality of life can be found in abundance in the head. Now, there are different types of sutural anatomy. Here I have a list of the different types. So you have serrate, which you see up here at the top, kind of like a very circuitous river. You have squamous, it's very flat. The temporoparietal suture is like this, and here you see a beveling. You see the temporal bone at this point being inwardly beveled, the parietal being outwardly beveled. This allows a gliding motion. The serrate one allows a rocking motion. So like when we look at the top of the head, how the parietals during flexion will do this, and during extension will do that. You can see how a serrate suture type will allow that very readily. So here, here's another thing. If you're still wondering, like, does the head really move? What would these sutures be doing here if the head wasn't moving? They would have fused up. Then they do in some people, but some people's heads get jammed up from injuries, so it would make sense that they fuse. Think about somebody with bad diabetic neuropathy. What happens to their foot? Their foot totally fuses up. If you don't have proprioception that's picking up the motion in the foot and helping to orchestrate it, the bones will fuse. And that's even with motion in the foot. Like the foot, they're still walking on their feet. They just don't have proprioception anymore. So in the head, if there was no motion, how could we have these articular surfaces that even at death, we can disarticulate? Like you're not going to be able to disarticulate a Charcot foot that's all fused up from someone who has diabetes. You can take a human skull, after someone's died, if all the tissue's cleaned off and you fill it with beans and put it in water, as those beans expand, they will separate out the cranial bones at the sutures. So, the head's definitely retains motion through life for most people, most of the sutures. And then these are harmonic. This would be like the lacrimal ethmoidal suture or the sphenobasal. Well, that's technically a synchondrosis. So that may not count as a harmonic one. I'm not sure if that one's classified as harmonic or not. But the lacrimo-ethmoidal one is. So it allows shearing, sliding back and forth. And then the squamous serrate would be a combination between squamous and serrate, and you can see that in the lambdoidal and coronal sutures. Oh, and histologically, we see ligaments when we dissect the sutures. So again, why would there be ligaments if there wasn't motion? Now here's a map of the bevel changes. So you see where the dotted lines are, the bone is beveled inward. Where the black is, the bone is beveled out. So if you got hit on the parietal at the top of your head, well, this is where you would expect it to get jammed up, because otherwise the parietal would kind of slide under the temporal. But here it gets stopped there. So it can't slide under the temporal like that. And then you have the SS pivot that isn't really shown very well down here. but you can find other diagrams that'll show you the SS pivot. That's a key point. And then you have it here on the occiput with the parietals. You have it here in the frontal bone. So when you get someone coming in with a hit to the head, if you know where your bevel changes are, you know the region really where you need to look for the area of greatest restriction. Just some more images for your edification. Most of us have all seen many pictures of the sphenoid, but just a few more there with its axis of motion. And here you can see the spheno-squamous pivot. That's why I put this one in here. So that's typically where if you get the sphenoid jammed back into the parietal bone, or if someone gets hit on the back of the head and the sphenoid jammed back on the temporal bone, or if someone gets hit on the back of the head and the temporal bone, occiput, temporal bone, sphenoid get jammed together, well then this is where you'll want to focus your attention to get it unstuck. Typically, not always, but generally. And here we have images of the base of the skull with all of these foramen for the nerves to exit. So you can see the mechanism by which nerves could get fouled up, because if you put strain either where they're contacting the tentorium, and there's a cool case study on that with an ocular palsy from the sixth cranial nerve being compressed by this kind of anterior lateral part of the tentorium as it's attaching into the sphenoid. I didn't include that here, but there certainly are mechanisms for cranial dysfunction to affect cranial nerves. So yeah, there's this, let me see. Oh, here we go. I gotta wait for this bottom thing. There you go. So ossification of all parts of the head isn't complete until about 5 years old. So there's some important significance in treating children. With children, we end up needing to be way more gentle than with adults. And there's this famous treatment for colic where we draw back the occipital condyles. And you don't have to be an osteopath with 30 plus years of experience to be successful with treating colic. If you're trained in this approach, you can pretty quickly get success with it. And it's amazingly satisfying because parents then get to enjoy that phase for their children. They go from like terrible sleepless nights and having to be very patient and enduring quite a bit. Then that can lead to irritability and arguments between spouses. And so instead of getting this beautiful reward of a smiling, happy baby, they're going through this very difficult challenge of their patience. And you can pretty quickly, sometimes in one treatment, but generally within 3, you can get them to have, it's like, they'll come back and say, I have a totally new baby. It's like, and then you see the baby come in and start smiling, and it's the coolest thing. This is more in depth of the temporal bone and its bevel patterns. And this isn't something that I expect that you're going to lock in this lecture. This is just to bring your awareness to this phenomena so that you know to go back and look at it and commit it to memory so that it's second nature. If you read the stories about how well Still knew his anatomy, he put all of us to shame. So we really, there's quite a bit of improvement, all of us can make in our knowledge of anatomy. And then imaging of the sacrum with showing the axis of respiration here around here in the articular surface there, and the cranial axis right there. And it rocks back and forth. So during flexion, the base of the sacrum will move back and then down at the coccyx end will move forward, and the opposite during extension. And that's because as the dura attaches at the sacrum at the second segment, it then pulls up during flexion as the SBS moves up, and then vice versa. And then with inhalation, the sacral base moves back. With exhalation, it moves forward. Here's a schematic for vault hold. Originally, when I did this lecture, we were going to have time to practice this, but we don't because we're not in person. But a good thing to do at home if you're not already grounded in cranial osteopathy, but you want to begin working with it. I would say one of the best pathways in that I really think should be standard in osteopathic school and in osteopathic training is meditation. So you get used to sitting down in an upright position where your spine can be erect, so you have good posture, good ergonomics, ears over your shoulder, rest your hands in your lap, close your eyes most of the way, turn your attention in, and just allow yourself to feel your breathing and keep your focus upon your breathing. Not trying to change the breathing, but just watching it. And then as you watch it, letting yourself relax. So extraneous thoughts will come up and you redirect your focus back to the breathing, and you let yourself relax into the breath more and more, where you let go of these other concerns as you notice them arising. And then as you let go of concerns and you give yourself permission to just be responsible for the sensation of your breathing, focus becomes easier. And you begin to get more information about your breathing. And now instead of just feeling, say, the motion in your belly, over time you'll begin to feel the motion throughout, your whole chest and throughout your whole body. And how, sensation is created in the whole body with inspiration and with expiration. And as you allow yourself to let the breath be more and more normal, as you influence it less and less as you witness it, then you'll relax even more deeply. And you get more still, and tension will come out from your body, and you'll just become more and more sensitive and perceptive. So if you cultivate that sort of practice, starting with 5 minutes a day, or maybe 5 minutes 2 times a day, even better, morning and night, and then you gradually build it up to where you're sitting for as long as your treatment sessions are. So if you're going to be treating someone for 45 minutes, well, then every day that you're treating someone, you're meditating in the morning for that same period of time that you're going to be in the treatment. So that you're first practicing maintaining the state without doing anything, without being responsible for anything additional. And so then when you go to contact someone's structure, it's going to be easier for you to quickly get into your neutral and to be able to be more available to perceive. Because if we're carrying tension, then we don't have as clear of a slate to receive information. So yeah, that's my opinion. All of us should be practicing meditation who are doing this work. And then, once you're in a sensitive state, then put your hands onto someone's head. Here in the vault hold is a great place to begin. Or the occipital hold that's depicted here, either one. Generally when treating, I'll start with the occipital hold, because if the base of the head is jammed up, then it's hard to get the vault moving. But for some people, it's easier for them to begin following the cranial rhythm by using the vault hold. So either one, but you just go ahead and make contact, and then you can't really try too hard to feel it. It's like one of those magic eyes where you kind of have to, you just look at it in a certain way and you have to wait. So you don't want to intently kind of hold yourself tight and just like waiting for this thing to happen. You want to be relaxed, but not too relaxed. For anyone who's played a string instrument or even a wood instrument, this idea of the right amount of tension, where the string is neither too tight nor too loose, where the reed there on the woodwind is neither tightened on too much or too little, where the armature for the trombone or trumpet or whatever is not, it's neither too tight nor too loose, and that's going to give you just the right sound. So you don't want to be so light that you're not connected. You don't want to be so heavy that you're obstructing things. And I got interested in Zen meditation back in 8th grade. And to me, since I learned about osteopathy and cranial osteopathy in particular, the parallels in the philosophy of treatment when you get into cranial osteopathy and the mind state recommended for Zen meditation are remarkably similar. This sort of, this balance of tension, this awareness with an allowing. So I think it's a very powerful resource to have in developing oneself as a cranial osteopath. Okay, so this marks the end of my lecture here. I think we did pretty good on time, right about an hour. I'm going to stop recording this, and then we'll start my next one, going over facilitated positional release and still technique. Thank you very much for your time and for listening to this. I know it would have been easy to just say you're not going to participate in the conference because it's not in person, but I acknowledge your commitment to learning. And if you have any questions about any of this or want to pick my brain about something we talked about, well, you'll have the opportunity during the, when you listen to the lecture, I'll be there. But you can also email me, info@drstarsIak.com. Thank you very much.